All right, back to business here. We're going to spend a few minutes talking about collaborative performance updates for the year. This grid looks at our quality initiatives, all our active ones, and we are in the green or trending in the right direction for PE. Woohoo! Yeah. Adult low risk chest pain and the naloxone offer rate. We are close on many of the ones that are currently in red. So keep up the good work. I think we can continue to make some improvements there. This is our VBR report looking at CT scans for adult minor head injury. The gray bars represent monthly performance, so month over month, starting in September of 2025. If you're in the green, you are meeting the target, which for this measure is greater than or equal to 62%. And the blue line represents the average. So still in the green technically, but trending down a little bit. So continue to keep an eye on that with your groups. Next, we have the pediatric intermediate risk head injury. We are cleanly in the green on this measure and well below the VBR target for this of less than 25%. So we will aim to keep up the good work with that one. This is chest x-ray utilization, also clear in the green for this one, less than 30% month over month. And heading into summer, which means hopefully those numbers only get better from here. This is looking at smoking cessation counseling. So the bottom graph there basically is the occurrences offered, monthly offer rate. And there were two options to meet the goal for this one. Option one is hitting greater than 30% smoking cessation counseling for 1 month of the calendar year, which has not been yet met. That's the top blue line. Or offer counseling to greater than 15% of the qualifying cases for 3 separate months within the performance period. And it looks like we've just achieved that in January, February, March. So great work with that. This is our asthma bundle. Again, one of our newer measures, more challenging. Our target here is set intentionally low as everyone comes on board and gets this up and running. We are technically in the green on this. Last month we have measured March 23%. Our goal for the measurement period is greater than or equal to 18%. So I think we got a lot of insight and tips and new methods we might be able to implement at our session this morning in thinking about continuing to increase compliance with the 3 pieces in this measure. And then our chest pain discharge rate, again, pretty much nearing the ceiling on this month over month at 98% for the most part, above the target of greater than 95%. So strong work there. And then PE, I think our target for this has been around 8%, and we were actually above that for the first several months of measurement here. Dipped down in March, but still we are average to date at 8.3%. So little dents add up over time, and I think we can continue to hope to meet the measure this year. All right, Andy's going to come talk about the executive committee opportunities.
Okay, so just a little bit of a reminder on what the executive committee is for Medic, and then kind of what the time scale that we're on. So the executive committee is voluntary committee, 9 elected clinical champions. Couple ground rules we have around that is that 1 seat has to be held by a pediatric physician. We try to be representative of as many health systems as possible. And the members serve a 2-year term. They are eligible for reelection. And so that's kind of what we do. So what we lean on the executive committee for is Um, one big thing is setting the pay for performance and VBR agendas, both picking which measures we're going to work on, how we distribute the points across the different measures, and then helping set targets. So our process on that is, the coordinating center and the executive committee work together, come up with a proposal, submit that to Blue Cross, work with feedback with Blue Cross, and then that scorecard gets published for the year. So that's a big part of the executive committee. Also, we really lean on the executive committee for, as we consider new things like changing asthma to an asthma bundle, or bringing on stroke work, that sort of thing. Like, really want to hear and get engagement from the physicians around the network to make sure that everything we're doing makes sense, is feasible on the ground in your EDs and all these different EDs across the state. So really, a very important part of our structure to kind of be able to just keep us on track. Everything's, we've talked about the great success we've had over the last 10 years, and to keep that going, we really need that partnership from the executive committee. So just as a heads up, this will happen in the fall, but we are in year 2 of the 2-year term of the current executive committee. So at the fall meeting, which will be in Grand Rapids in October, we'll kind of start the election process, and it's, fill out, it's a Qualtrics thing. And we'll have you rank each clinical champion. Each site will get 1 vote. Actually, you vote for 9 people, kind of like a rank ordered vote. It's for that new 2-year term that starts in January of 2027. So something to think about if you are on it and you don't want to be on it, or if you're not on it, you do want to be on it. This is an opt-out type deal, so you're on the ballot as a clinical champion unless you tell us to take you off of it, which is fine. We'd love to have you, but if if it doesn't fit with your scope of what you're doing, basically let me or Megan know in the next month or couple months that you do not want to be included, and then we'll get that election going again in the fall. Any questions about responsibilities, time commitment, anything about how the executive committee works? And again, like, very important, and we'll say this again, but like, sincere thanks to those people who volunteered to do it. It's can be a little tedious at times, but it's important work that makes definitely makes a difference in how everything works for us. Okay. A couple other things just that I have to talk about, just for awareness, opportunity for national recognition. ASAP has its QI challenge going on now. Applications are due by June 27th. Criteria are listed up there, just something that, if there's anything Medic can do to help. It's kind of close to the deadline, but, want to get our work out there, your work supported. So just want to make sure you're aware of this opportunity. Another reminder, for publications, posters, and abstracts, we have templates online that you can use. You don't have to use using Medic data. If you do want to use Medic data beyond your site's data, you can make an application or fill out a form with the Medic Data and Publications Committee, where that kind of gets vetted and we figure out how we can do that. That's happened. A lot of sites have done that, that want to use, bigger data sets. Let the coordinating center know. And just a reminder that if you do publish off of the Medic data, there's a Blue Cross disclosure that has to be included on that. And we can talk to you about that as you, ideally as early as possible in your process of doing the actual work. But we want to, there's a ton of good stuff going on. We want to highlight your work. So please, we'd love to publish, and we'd love to work with you to get that done. Relatedly, just a reminder that we have our call for posters. So our fall meeting is at the Sheridan in Grand Rapids on October 16th. We'll have a poster session. Really, anything ED related that you're working on. It does not have to be the Medic initiatives. It doesn't have to be something that you made just for our meeting. If you presented it at a different meeting, internal, we'd love to have it. Good opportunity to share your work around the state. And another thing, like, fellows, APPs, learners, residents, that it's a very, I don't know, low bar of entry to, like, get something presented, and we'd be happy to work with you to put it together. So I think it's always really cool to walk around and see what people are working on. Sometimes even the non-medic stuff is cooler than the medic stuff. So, or it's unique, at least different, new to me. So maybe that makes it more interesting. But yeah, it does not have to be limited to stuff that comes from medic work specifically. So deadline for that is October 2nd, really only just to make sure we have enough stands and, resources to present everything. So fortunately, any questions, email Megan. She will get you pointed in the right direction for that. But please, it's very cool. Bring your stuff if you got it. Okay, so last one for me is just a minute to talk about the stroke FTE allotment that is happening now, and just to try to lay the groundwork for like what this means to the people in this room and where this is at. So medic every year we submit the amount of FTEs that your hospital gets for abstraction in April or May, April, and then that kind of is effective for the fiscal year that goes July to June. And so with the stroke work coming on this year, the FTE amounts that were submitted to Blue Cross in April and then will go into effect in July include a small part for stroke work. So those Medic communicated out what we submitted to your administrators in May, a couple weeks ago. So they should know how many FTEs you're getting. And we split that up between standard medic work and stroke work. And that'll be, again, that's effective for July through June. The way it's currently set up in the system is that you are going to see, well, probably not you, but the person at your site who gets these letters from Blue Cross will see FTE support amount that comes from medic, and it'll just be one number. It will not be like split between stroke and traditional medic. So we wanted to get that out there because when you think about what resources you're allocating to kind of the traditional medic, don't just go based off of the number that's in that letter from Blue Cross. Go by what I sent to your administrator, because that shows you the differentiation between what we're expecting for the stuff you've already been doing medic work and what stroke comes from. So, and there will be no way to like separate that out based on the letter that you get from Blue Cross. Yeah. So the way that this is set up, this is all still in development, but the way this is going to work is that you only will get support, FTE support at this stage of this if you're already participating in the American Heart Association's Get with the Guidelines program. So if your hospital is doing stroke, but not through, well, if your hospital is not doing the Get with the Guidelines stroke initiative, that's going to be our source. That's going to be our source of data for this. So kind of importantly to point out to the abstractors is that we are not expecting medic abstractors to become stroke abstractors. It's a system that already exists. We've heard strongly from people, administrators in hospitals around the state that there's already the AHA, there's already a Michigan Stroke Program. They really don't want a third totally different stroke initiative. So and I think we said this, our vision is that we are going to try to work with the American Heart Association to build off of the work that they're already doing and the data they're already collecting and leverage that to measure and incentivize your stroke work. We will work with the AHA to probably supplement that a little bit, add a few questions, but you don't need don't need to learn a new platform. You don't need to set up a new data feed. So in your hospital, there's a lot of like legal and compliance that goes along with this, getting data use agreements. But the vision of this is to build CQI stroke work off of the data that you're already collecting to Get with the Guidelines with some tweaks as the program grows. But again, the message, like for the abstractors, like we don't expect you to start doing stroke in July. Like that's not what we're doing here. And the goal of this support is to, we're going to, as long as your hospital agrees, be getting this data from you to do this program. And the goal of the support is to subsidize the work you're doing and to support if we want to add in some questions to Get with the Guidelines about different areas to kind of supplement that work and to enrich the data source to make it usable for CQI work. So I've gotten a ton of questions. I think to me, the take home on this is like one, like I said, for abstractors, like you don't have to learn stroke. I mean, I guess your hospital could assign you to it, but like we are not asking you to become a stroke person now, and then we're going to work within the system to this is really not supposed to be duplicative and redundant to work that's already happening. It's supposed to be, enrich the data, supplement the data, add another source of collaboration and incentives around stroke, but not create a whole new mode of work that's going to be a burden on your hospital. So that's what we're shooting for. It's a tedious, long, slow process, but that's where this is going, and how that incorporates into Medic as a whole. We'll still figure like parts of meetings and stuff like that. We'll work through, but that's the vision of where we're at with stroke and with FTEs. What questions can I answer about that? Because I've gotten a lot of questions. Okay. Email me, call me, text me, let me know. Like again, it's my full-time job. We're happy to help you understand what we're doing here. Okay, last one for me. Just a reminder of our smoking VBR. As Courtney mentioned, the way this works is that to be successful, you need to get 1 month at 30% smoke, 30% counseling referral in 1 month, or 3 months at 15%. So theoretically, if you're not doing this now, the VBR year ends at the end of August. So if you got really fast with your IT and got it set up, you could maybe pull it off this year if you wanted to get into it. It's probably pretty unrealistic, to be honest. But for those sites that are working on it, the nice thing about this one is it's never too late. You just got to nail one of these months. So you got a couple months left to try to get your smoking referral rate up to get the VBR. Questions on smoking or anything that I've talked about for the last few minutes? Okay. Find me later if you have them. All right. Keith is going to come talk about some naloxone stuff.
Yeah, so I'm going to cover some of the business side of today related to some of the measure adjustments and talking through some of the things that we've gotten feedback related to 2 of our measures. I do want to just kind of underscore, though, the ACEP QI award. In a kind of past moment in my career, I was the chair of the ACEP's National Quality and Patient Safety Committee. So was on the receiving side of these awards. The bar is pretty low to apply, to be honest. It's like a paragraph or 2. And you, as a site within Medic, really have an advantage because you have access to data, you have access to a story. So really, like any of the presentations that we heard today from our sites, like those are perfect examples that you could apply for an award for. And it's national recognition, probably something you could talk to your hospital about, probably something that could be important, kind of local recognition of good work. And we're happy to help you with an application if you're interested. Okay, so I'm going to talk about first naloxone, and then I'll talk about the pediatric asthma measure. There are 2 points we want to make on naloxone. One is going to be an adjustment in the way that we, when I say we, the abstractors will interpret charts tied to overdose. We're going to make this change to align with the 2027 P4P year, just to make it like an even transition. One of the things that we're sort of noticing in some of the feedback and review of records is we're really been sort of keying in on this specific term of overdose. But what we, I think, recognize is like overdose has a big spectrum. And so I think when we document as clinicians, we tend to use that overdose term mostly in the context of somebody that had used opioids but had, say, respiratory depression or required like naloxone for recovery. But we're leaving out kind of a spectrum of patients that used opioids, had some effects from those opioids, sought help in the emergency department, and could totally benefit from naloxone. So somebody that used, their prescriptions or some street version of opioids didn't need rescue from naloxone, but needed medical attention. And we don't want to miss that population within the measure. So it's not really anything that we need to do or adjust per se in the documentation. We're just going to educate the abstractors and adjust or how we interpret that type of patient when we're reviewing the records. So there'll be some education that we roll out over the next couple months related to this, and we're just going to try to time that change, with the switch to the next P4P year. I got one other thing on naloxone, and then I'll just pause and see if there are any questions about this. So this is more of like a kind of educational moment. So one of the things that we've heard from sites at times is, at least from my point of view, like a misinterpretation of how naloxone fits within somebody prescribed buprenorphine or Suboxone who have, documented opiate use disorder. I've actually gotten emails from people saying, like, I didn't need to prescribe or offer naloxone for somebody on Suboxone because it's already got naloxone like in the product. And that's certainly true. Naloxone is built into Suboxone, really is a counter to misuse. If you were to, inject or snort Suboxone, that naloxone becomes active and would, reverse somebody that's trying to abuse Suboxone. But that's not really the point of actually giving naloxone to those individuals. These are folks with opiate use disorder. As we know, opiate use disorder is a chronic relapsing condition. They're always at risk of relapsing. There's always a risk of using other types of opioids. Really, Suboxone has kind of low abuse potential. But the risk is always there for those who may use opioids in other ways. And so those individuals really need naloxone available to them. So I just want to make sure that we in the room kind of understand the rationale behind why individuals prescribed Suboxone still need rescue naloxone available to them. And these are really kind of the recommendations from national guidelines that we're following. So I'm going to pause there, see if there are any questions about kind of the naloxone measure or sort of how it intersects with Suboxone. Make sure we have all those kind of questions out to address. And certainly, happy to follow up with any offline too. Okay, I'm seeing none at the moment. So this is the other measure that we want to talk through. So I think this is a good example of how your feedback to us, allows us to adjust our approach to measurement. So this is with respect to the bundle. This is one of these examples where it's not something that we would have anticipated as a common occurrence that may be going on is in asthma care, kind of out in the real world. But what we heard back is there are going to be examples of children coming in with an asthma exacerbation, but not at the level that you actually have to provide bronchodilators. And so the question was like, okay, if we're not really kind of actively treating with the intervention like bronchodilators, do we really need to do like 2 serial asthma assessments? And I think there's good rationale there. The reason that we advocate for 2 or at least 2 serial exams is because, that's what's been demonstrated in the literature to provide better asthma care because it standardizes practice. It provides sort of common language. We've heard kind of examples of that from the site presentations this morning. But at the same time, we don't want the documentation to be a burden. And it certainly doesn't make sense, if you're not really giving an intervention, if you're not giving bronchodilators, why force like a second exam? So in those instances where this actually comes up, we'll be able to do this electronically, sort of modify like how we do the measurements. So you wouldn't have to, force that second assessment, in the instances where you're not giving bronchodilators. That's the bottom line. And we'll just make that adjustment, in the way that we do the electronic measurement. And that's going to go live next week, I guess.